Welcome to the Deep Dive, where we take the sources you give us and really break them down into knowledge you can actually use.
Today, we're tackling some revision notes you've shared. It's a deep dive into a pretty complex, really important topic, schizophrenia.
Yeah, and our goal here is basically to unpack these notes together. We want to pull out the most crucial bits, the high-yield stuff, and make sure it sticks for your revision.
Think of it like a focused study session, highlighting the key facts so you feel, really equipped to understand this condition based on this material.
Okay, let's jump right in. According to these notes, what exactly is schizophrenia? Let's unpack that definition.
Right, so at its core, the notes define it as a chronic, severe mental disorder. It fundamentally affects how a person thinks, feels, and behaves.
Okay, chronic and severe,
Yeah.
affecting thoughts, emotions, behavior.
Exactly. And the key characteristics mentioned are psychotic symptoms, things like hallucinations and delusions, plus these disturbances in thinking and social interactions.
The notes specifically highlight recurrent psychosis, disturbances in thought, perception, emotion, language, and behavior. So it's quite wide-ranging.
And they list different forms too: paranoid, which is noted as the most common, then hebephrenic and catatonic.
And a key point seems to be that it's described as a lifelong condition, often with chronic or sort of relapsing episodes.
Absolutely. It's not usually something that just goes away.
Yeah.
And importantly, the notes acknowledge it impacts not just the patient, but their families and friends too. A huge ripple effect.
Okay, that gives us a solid foundation. Now, the why. What do the notes say about the etiology, the causes?
Well, they make it clear it's complex. There isn't just one single cause.
Right. It's presented as a combination of genetic factors, environmental influences, and neurochemical stuff going on in the brain.
Yeah, and on the neurochemical side, the notes specifically call out imbalances in dopamine and glutamate systems as contributing factors.
And genetic predisposition, that seems to play a clear role in susceptibility.
Definitely. But here's something the notes really emphasize, and it's interesting for revision. Substance abuse is linked to increased risk.
Ah, okay. Which substances?
Cannabis is specifically mentioned. That link between cannabis use and increased risk is a detail worth locking down.
Got it. So complex interplay, genes, environment, brain chemistry, and potential triggers like substance use.
Which leads us nicely into the risk factors. Who's more likely to be susceptible? The notes list quite a few.
Family history seems top of the list.
Absolutely. It's stated as the strongest risk factor. The notes even give relative risk figures, having a parent with schizophrenia, a relative risk of 7.5.
Wow, 7.5 times the risk. That's significant.
It is. And there are other stats. If you have an identical monozygotic twin with it, the risk jumps to around 50%. A sibling is about 10%, compared to just 1% in the general population with no affected relatives.
Those numbers really put the genetic component into perspective. What else?
The notes also mention other factors, things like complications during pregnancy or birth intrauterine or perinatal issues, infections during pregnancy.
Okay, so early life factors.
Yeah, and abnormal early development, social isolation, growing up in an urban environment. Even difficult family interactions like hostile or critical parents are listed.
Specific environmental triggers, too.
Prenatal exposure to infections, childhood trauma, those were explicitly mentioned. And again, substance abuse, particularly cannabis, reappears here with a relative risk noted as 1.4.
So that cannabis link keeps coming up?
It does. And finally, some demographic or broader environmental risks mentioned are Black Caribbean ethnicity, migration, and again, that urban environment factor.
Okay, quite a list of interacting risks. So let's get into the brain itself. What do the notes say about the pathophysiology? What's actually happening?
They describe abnormalities in both brain structure and function.
Which ties back to the neurochemistry, right? Dopamine and glutamate.
Exactly. Altered neurotransmitter activity, particularly in those dopamine and glutamate systems. It involves dysregulation in specific brain circuits.
Did the notes mention which circuits or areas?
Yes. They name the prefrontal cortex, the hippocampus, and the striatum as key regions involved.
Okay, areas linked to planning, memory, emotion, reward.
Precisely. And the notes connect these structural and functional changes directly to the symptoms. They contribute to the cognitive, emotional, and perceptual difficulties you see in schizophrenia.
Makes sense. Understanding the where helps understand the what. Now, differential diagnosis. This is super important for revision. What else could it be?
Crucial. The notes provide a really helpful list, grouping things together. First up, organic disorders that can actually mimic psychosis.
Right, you absolutely have to rule these out. What's on the list?
Drug-induced psychosis is a big one. The notes
Great.
give examples like amphetamines, LSD, and, yes, cannabis again.
Okay. What else organic?
Temporal lobe epilepsy, encephalitis, alcoholic hallucinosis, even dementia.
And delirium, that's a major mimic, isn't it?
Huge. Caused by all sorts: infection, metabolic problems, toxic issues, neurological diseases, endocrine disorders. Got to think broadly. The notes even mention cerebral syphilis, rare, but apparently incidence is rising.
Okay, so rule out organic first.
Right.
Then what about other psychiatric conditions?
Yeah, the notes list mania from bipolar disorder, severe psychotic depression, some personality disorders, even panic disorders, and dissociative identity disorder can sometimes overlap or be confused.
So careful assessment is needed to distinguish.
Definitely. And one more category the notes include is associated conditions. These can overlap or coexist.
Like comorbidities.
Exactly. Things like depression, anxiety, PTSD, personality disorders, substance misuse, we've seen that already, but also physical health issues. Obesity, diabetes mellitus, specifically type 2, which is often linked to the medications used.
Ah, that's an important practical point.
Also general infections, cardiovascular diseases, and the sort of ongoing disability that can come with the illness. It's a whole person picture.
Okay, let's zoom out again. Epidemiology. How common is this? Who gets it?
The notes state it affects around 1 in 100 people in the UK. So prevalence is about 1%.
1% and onset.
Typically emerges in late adolescence or early adulthood. There's a peak after age 15 mentioned.
Does it affect men and women differently?
It affects both, but the notes say men tend to develop it slightly younger. And importantly, symptom presentation and the course of the illness can vary a lot between individuals.
Right, not one size fits all. So what does it look like? Clinical presentation. The notes use the classic positive versus negative symptoms split. Right?
They do. It's a really fundamental way to think about the symptoms for a revision. Positive symptoms are sort of added experiences, things that are there but shouldn't be.
Like hallucinations.
Exactly. Hallucinations, which are often auditory hearing voices. Delusions, which are fixed. False beliefs. Thought disorders like disorganized thinking or speech. It's something called passivity phenomena.
Passivity phenomena. What's that exactly?
It's that feeling or belief that your thoughts, feelings, or actions are being controlled by some outside force. A really distinct feature.
Okay, so those are positive symptoms. What about negative ones?
Negative symptoms are reductions or losses of normal function. Things missing. The notes list reduced motivation, sometimes called avolition, social withdrawal, emotional flattening or blunting, and self-neglect.
These sound like they could have a huge impact on day-to-day life.
Massive impact.
Yeah.
And they can be harder to treat sometimes than the positive symptoms. The notes also mention a prodromal period.
Yeah, what's that?
It's a phase where there might be subtle changes in behavior or personality before the full-blown symptoms kick in. Sometimes even brief, sort of transient first-rank symptoms might appear then.
And the diagnosis itself is mainly clinical, based on these features.
Primarily clinical, yes, based on assessing these features, including what are called first-rank symptoms.
Schneider's first-rank symptoms.
That's the ones the notes specifically mention them. Certain types of auditory hallucinations, like voices commenting or arguing, thought disorders, like thought insertion, withdrawal, broadcast, those passivity phenomena we mentioned, and delusional perceptions.
Delusional perceptions.
That's when someone attaches a bizarre delusional meaning to a normal perception, like seeing a red car and knowing it means the world is ending. These first-rank symptoms are classic, often tested.
Good to know. And comorbidities come up again here.
Yes, the notes reiterate common ones seen alongside schizophrenia. Depression, anxiety, sometimes obsessions or compulsions, and again, high rates of alcohol or substance misuse.
Okay. So given it's a clinical diagnosis, how do investigations fit in? What tests might you run?
Well, the notes are really clear. The diagnosis relies primarily on the clinical evaluation. That means a thorough psychiatric history, a mental status exam, and careful symptom assessment.
So the tests are more for ruling things out.
Exactly. Additional investigations are mainly to exclude those organic causes we discussed earlier in the differential diagnosis section.
Like brain scans and blood tests.
Precisely. Brain imaging, like an MRI, and various lab tests fall into this category. The notes list the typical diagnostic workup, basic bloods, FBC, UNEs, thyroid function tests, checking calcium levels, urinalysis, and importantly, a urinary drug screen.
Right, got to check for drugs.
Definitely. And cranial imaging, CT or MRI, if you have any suspicion of a neurological cause.
What about ongoing monitoring?
For long-term management, Things like ECGs and further blood tests are needed to monitor for potential toxicity or side effects from the antipsychotic medications.
Makes sense.
And there's a special mention for first episodes, doing LFTs, FBC, serological tests for syphilis, that urine drug screen again,
Yeah.
and assessing specifically for intoxication or drug overdose presenting as psychosis. Got to be thorough first time around.
Absolutely. Okay, so we've identified it, ruled other things out. How is it managed? What's the approach?
It's a multimodal approach, according to the notes, not just one thing. It's about combining antipsychotic medication with psychosocial interventions and various support services.
Right, a team effort. What about emergencies?
In severe cases or crises, the notes mention that inpatient psychiatric units, or even sectioning under the Mental Health Act, might be necessary for safety and intensive treatment.
Okay, and medications.
Antipsychotics are key. The notes list atypical antipsychotics, like risperidone, olanzapine, as first-line treatment. Clozapine gets a specific mention for treatment-resistant cases.
Any notes on side effects?
Briefly, yes. Atypicals tend to have fewer of the classic movement side effects, the extra pyramidal symptoms, compared to older drugs. But, and this is a big one, weight gain is a common concern, which links back to those risks of diabetes and cardiovascular issues.
That connection again. What about non-medication approaches?
Hugely important. Psychological support includes education for the patient and family therapy, and cognitive behavioral therapy, or CBT. The notes actually state CBT is offered to all patients.
Wow, offered to all. It highlights its importance.
It does. And then there's social support, addressing practical needs, housing, help with work or training, vocational support, tackling social isolation, employment issues, financial aid, supporting the whole person.
And you mentioned the physical health risks earlier.
Yes, and the notes emphasize that cardiovascular risk assessment and management are really important parts of care due to that increased risk. Also, treating any substance misuse and other physical health problems is vital.
Any other treatments mentioned?
Electroconvulsive therapy, ECT, is noted as a consideration, usually for treatment-resistant cases or specific situations like severe catatonia.
How is the care typically structured?
Often it's shared care, especially for stable patients, between primary care, the GP, and the secondary care specialist mental health services. GPs might handle routine checkups, often keeping patients on specific mental health registers. Secondary care usually manages medication adjustments and more complex care.
And there are specific teams involved?
Yes, the notes list crisis resolution teams for acute help, home treatment teams that provide intensive support in the person's home to avoid hospital admission, and community mental health teams for longer-term, ongoing support and care coordination. It's a network.
So the overall approach is comprehensive.
Absolutely. Comprehensive care is the goal. Managing symptoms, improving daily functioning, preventing relapses. It needs collaboration between everyone involved and, crucially, an individualized treatment plan focused on holistic management, tailored to the person.
Okay, so looking down the road, what's the prognosis? What do the notes say about the likely outcome?
Well, the first thing to say is that it varies significantly between individuals. It's not a uniform path.
Are there factors that suggest a better or worse outcome?
Yes, the notes list several positive prognostic factors, things associated with a better outlook, like absence of family history, good functioning before the illness started, what they call good premorbid function, having a clear trigger or precipitant for the first episode.
Okay.
Also, an acute, sudden onset rather than a slow, gradual one, having mood symptoms like depression or mania alongside the psychosis, getting prompt treatment, and the person managing to maintain initiative and engagement.
And the flip side, factors linked to a poorer prognosis.
These include a longer duration of untreated psychosis, meaning a long delay before getting help. An early or insidious gradual onset, being male is listed, having prominent negative symptoms, a family history of schizophrenia, lower IQ, low socioeconomic status, social isolation, a significant prior psychiatric history, and again, substance misuse.
So quite a few things can influence the course.
Definitely. But the key message from the notes, despite the challenges, is that early diagnosis, getting the right treatment, and having ongoing support can lead to significant symptom improvement and allow people to lead fulfilling lives. But it often is a chronic disorder needing long-term management.
Right. Finally, let's cover complications. What potential difficulties or issues can arise?
The notes list several. Social isolation is a big one, difficulties with employment, substance abuse, which is both a risk factor and a complication, and tragically self-harm is also mentioned.
And the physical health issues again.
Yes, that increased risk of other medical conditions and other co-occurring mental health disorders comes up here too.
What are the consequences if it's untreated or poorly managed?
The notes stress these can be really significant. Major social and occupational impairment, a reduced quality of life that increased risk of self-harm or suicide, problems with substance abuse, medical comorbidities piling up, and serious challenges in maintaining personal relationships.
So the stakes are high for getting management right.
Absolutely. Which is why the notes wrap up this section by emphasizing that regular monitoring, continuous support, and reliable access to mental health services are just crucial to minimize these complications and really promote recovery and improve quality of life.
Okay, so we've really covered the ground laid out in these notes: definition, causes, risks, brain changes, differentials, how common it is, what it looks like, investigations, management, prognosis, and complications.
Yeah, a comprehensive overview based on the source material.
As we were talking, particularly about the associated conditions, the medication side effects, the complications, one thing that really struck me was how often the link between schizophrenia and physical health problems came up. Things like obesity, diabetes, cardiovascular disease, they were mentioned repeatedly.
It's a strong theme in the notes.
It makes you think, doesn't it? It sort of raises this question: how integrated does the management of someone's physical health need to be for optimal care when they're dealing with a serious mental health condition like schizophrenia? It's clearly not just about the mind. The whole body is involved, something definitely worth pondering as you continue your revision.
That's a great point to reflect on.
So that wraps up our deep dive into these schizophrenia revision notes. We've gone through section by section, pulling out the key info.
Hopefully breaking it down like this, talking it through, has helped clarify things and make it a bit more digestible for your own study.
Remember, the whole idea of a deep dive like this is to get you well-informed, efficiently, focusing on those essential nuggets from the source material you provide.
And for those of you specifically revising for something like the MSRA exam, you mentioned finding notes like these helpful. The notes also pointed towards passthemsra.com and freemsra.com as places you might find more resources.
Definitely worth checking out if that's relevant for you. Thanks so much for joining us for this deep dive.
Yeah, thanks everyone. Keep those sources coming and we'll keep digging in.